We'll start in about 1 minute, folks. In about 1 minute.
Okay.
All right. All right. Thank you guys for joining today. Super excited to have this conversation. And, before I get started, please, the ask for the group is to make sure you stay on mute, make sure you keep your cameras off unless called on accordingly. We're going to go over quite a bit of content here. So the excitement here is to kind of share with you what we have. So again, this is the BAM-HLS team. We've put together a great session for you guys. But before that, we just want to mention this is our session that was pre-recorded, was recorded and available for folks. So if you actually go to the stream or this link below, you'll be able to see what we covered in the first session around vaccine awareness. Going into this session, the excitement is we really get to continue that conversation. So without further ado, I am going to pass you over to one of our esteemed committee team members, Jamal Dent, and I'll let him do the intros from there. So Jamal.
Thank you, Alfred. Welcome, everyone. It is my pleasure to introduce you to Dr. Jayne Morgan, who is a cardiologist and the executive director of the COVID task force at the Piedmont Healthcare Corporation in Atlanta, Georgia, the largest healthcare system in Georgia. Within this role, she serves as the COVID vaccine expert, analyzing the data and science from Piedmont and nationally. She also drives efforts addressing vaccine hesitancy via education to internal staff, external stakeholders, media, and the greater external community. Dr. Morgan has been named to the Health Equity and COVID Task Force for the governor of the state of Georgia and selected to support the Department of Health in its series of Ask the Experts. Additionally, she serves as a CNN medical expert contributor and is the owner and creator of the Stairwell Chronicles, a social media series directed towards addressing questions surrounding COVID vaccines in a conversational format. Dr. Morgan currently serves as the president of the Southeast Life Sciences Association, the single largest biotech association in the Southeast. She is also an adjunct assistant clinical professor of medicine at the Morehouse College of Medicine. She is the co-chair of the Health and Human Services Conference 2022 and serves as a board member of the National Diversity and Inclusion Team at the American Heart Association. We only have an hour with the brilliant Dr. Morgan, so we will post her complete bio for you guys to read later. And with that, I'll turn it back to you, Alfred, or straight over to Dr. Morgan.
Yep, Dr. Morgan.
Yeah, thank you. I appreciate it. What a great introduction. I'm so happy to have the opportunity to come today to talk to this group and to answer your questions about COVID. I specifically asked if you all would submit questions because as we are a year and a half now into this pandemic, I've given lots of talks and lots of lectures and speaking engagements. I really find it instructional and helpful if I'm really answering the questions that you have at this point in the pandemic, as opposed to me talking. I can certainly fill in lots of time talking about all kinds of information and data, but I'm really happy that you submitted questions. We'll address the questions. If there is time at the end, I can talk about other topics of interest that you might have. Merck is coming out with the pill, boosters, immunocompromised, all kinds of things.
Hey, real quick, Dr. Morgan, if you could turn your camera on, that'd be perfect.
We have all manners of situations here. So why don't we just start with the questions then?
All right, let me pull them up and then we'll go from there.
We'll just go right into the questions. And while we're waiting on that, I'll give you guys a little bit of a background on me. So I am a native Atlantan. I graduated from Spelman College. I was born right in Atlanta. I am a cardiologist by training. And after Spelman, I went to Michigan State for medical school, George Washington University for internal medicine, and then Mount Sinai for cardiology. I practiced for several years and then joined a pharmaceutical company, Solvay, and then later a device company, Abbott, and spent many years really just in hardcore R&D. So I really understand this vaccine development process very well. I led the cardiorenal divisions there. I've been at Piedmont for the last 6 years, leading their cardiovascular research program and then research across the system with regard to our organ transplant programs, our pulmonary, our oncology. And then COVID hit, and I have been leading this COVID task force for the last year and a half. So that is me. And without further ado, looks like we're getting started. So, question number one. For pregnancies, I'm reading this, I don't know what you all see. For pregnancies, if an individual has been vaccinated and following recommendations for wearing masks, social distancing, etc., are there additional ways to mitigate an elevated risk of both infection and health impact? First of all, if you're pregnant and you've been vaccinated, congratulations. We absolutely want to encourage all women who are pregnant and also desiring to be pregnant to be vaccinated. This is from the American College of Obstetrics and Gynecology, the American Academy of Pediatrics, the American Society of Maternal Fetal Medicine, and the American Society of Reproductive Medicine. So we know that these vaccines are safe and effective in pregnancy, and we know that they protect the mother and the fetus, the unborn baby, from harm. We have certainly seen in this fourth surge that we are in now, even though we're turning the corner with this Delta variant, we have seen the highest rate of maternal and fetal mortality, meaning mother dies, baby dies, that we have seen at any time during this pandemic. So we absolutely, absolutely, absolutely want pregnant women to get vaccinated. So if you're doing all of these things, if you're vaccinated and you're following good public health measures, that is awesome. If you want to go to the next step is to create your vaccination pods, socialize, mingle, interact with other people who are also fully immunized and have been vaccinated, to always make certain, in as much as you can, that you are in an environment where the virus has little opportunity to find a human host and threaten both mother and child. So these sort of vaccination pods. I don't know if you're traveling or not. I would try to mitigate or minimize your travel. Certainly if you are traveling by airplane or any type of transportation where you're in a closed-in space for a long period of time. And the fact of the matter is, it's not necessarily the airports or the airplanes, because both of those so far have been very well regulated with regard to requiring masks. And I think that that is awesome. But it's the navigation of getting to the airport and the navigation of getting out of the airport, the Uber, the Lyfts, the taxis, the hotels, all of the things that you're coming in contact with that you can't control. So I hope that's helpful, and congratulations on being vaccinated. I had the Moderna vaccine back in February. Is the efficacy still high after 9 months? So here's the answer to that question. I'm going to answer that in a number of ways. We don't have the Moderna information yet. However, we have the Pfizer data. Pfizer, which was first to receive its emergency use authorization, has a 95% efficacy, meaning how well it works, if you remember that number. When they looked at the data that was submitted to the FDA for full FDA approval, and that data was submitted in May, and that data went up through May, it turns out that the efficacy wanes over time, meaning how well it works decreases over time. And the further away you are from that second dose of the messenger RNA vaccines, meaning Moderna and Pfizer, you start to experience a drop in your immunity. Now, is this significant? Here's the answer to that. Pfizer's immunity dropped, its efficacy dropped from 95% to 91% when they looked at that 6-month data. The caveat to that is that that was independent of the Delta variant. That was in May, prior to the Delta variant taking hold. And so we don't know what that efficacy is in the face of the Delta variant. We certainly saw in Florida where cases were running rampant and there were not really mask mandates. There was not encouragement to take the vaccine. We saw breakthrough infections in people in Florida with that high prevalence of disease in the area, more likely to occur in the Pfizer patients than remembering. Unexpected because Pfizer came first to market. And so people who have had Pfizer by and large might have received it earlier. So the question then is with Moderna. Moderna and Pfizer are both messenger RNA vaccines. And so we are anticipating that the effectiveness or efficacy of the Moderna vaccine will also show this waning effect at the 6 to 8 month mark. We don't have that data, so that's an extrapolation because both Pfizer and Moderna are messenger RNA vaccines, but that is what we are anticipating, but that data still has not been reviewed. So if this question is around seeking boosters, if you had your first 2 doses of Moderna, we do not recommend that you go out if you are past the 6 month to get a 3rd dose of Moderna. We recommend you waiting to see what the data is going to show with the FDA. If you took Pfizer and you are 6 to 8 months out, the Pfizer booster is only recommended if you are 65 years of age or older, or are at risk for severe disease should you be infected with the COVID virus, and that includes pregnancy, is listed as at risk for severe disease, or you are a healthcare worker there on the front line. So we are expecting that the Moderna efficacy will also wane somewhat, but don't forget, even at this 90%, and even with the Delta variant putting our vaccines under serious challenge, they still prevented hospitalization and death at greater than 97%. This past surge that we are just rounding the corner in showed hospitalizations in every single hospital across this nation. Talk about reproducible data. Exactly the same in Idaho as it was in Georgia, as it was in New York, as it was in Arizona. All the same, 97% of patients admitted to the hospital and in the ICUs were unvaccinated. So the vaccines, even though some people got breakthrough infections, still kept you out of the hospital and kept you out of the morgue.
Hey, Dr. Morgan, I do believe that we have a question. Joshua, if you want to come off of mute and ask your question of Dr. Morgan, that'll be great. Okay, well, we gave Joshua a chance. Maybe he'll come back on. So Dr. Morgan, let's proceed.
Yeah, let's get through these questions. Okay, number 3. It seems that a lot of hesitancy is because the vaccination doesn't prevent COVID-19 and its variants. Further, we've seen people who've been vaccinated die after contracting COVID-19. How do you instill confidence in those who don't see a way forward with or without the vaccine? So here's what the vaccines do. They prevent you from hospitalization and death. The Delta variant changed the game. It was 100% before that Delta variant. If you recall, Dr. Rochelle Walensky, the director of the CDC, came out and said, if you have been vaccinated and are fully immunized, you can now take off your mask, both indoors and outdoors, because we knew that if you were vaccinated, your risk of hospitalization and death were almost zero with these vaccines. But the Delta variant changed the story. Why? This Delta variant came along and had a viral load that was 1,200 times higher than any variant that we had seen. That is huge. Those are the number of viral particles that you're carrying in your nose and in your throat. Your viral load determines how infectious you are to others, how contagious you are. It also can determine how sick you're going to become. So with a viral load that high, we saw our vaccines starting to be under challenge. And we didn't see that 100% prevention of death and 100% prevention of hospitalization. It was 97, 98. That's still pretty darn good. So there was a 2% risk now. We also saw that Dr. Walensky said, please, everybody, get your mask back on. That's because that viral load is so high that even though if you're vaccinated, by and large, you're protected from hospitalization, from death, and 98% from infection, we also know that because of that viral load, you could be infectious to others, not to the degree of someone who's not immunized, but you do now have the capability of infecting others. So that is what happened with the Delta variant. One of the reasons we want people to get immunized and to get vaccinated is so that we can stop having these Delta variants. The variants develop in people who are unimmunized. They find hosts. Human beings are the host in the life cycle of this virus, this SARS-CoV-2 virus. It invades our bodies, and then it does what viruses do. They replicate, and these replication errors are called mutations. And we've seen during this pandemic, this situation get worse and worse and worse. That is why at the beginning of the pandemic, scientists said, everyone, please shelter in place, because we knew that without human beings, if the virus could not find a human host, it literally would die. And so the recommendation was withdraw yourself from any place where the virus can find you for 60 to 90 days. The virus would completely die. It has no ability to survive without humans. But, you know, we couldn't do that. And so here we are now, a year and a half later, with all of these variants. And let me talk about the difference in these terms. We talk about variants now. If you recall, we used to talk about mutations. Then somewhere along the way, we started talking about variants. Those are not innocuous terms. That is a very specific scientific word that denotes an escalation. Here's the difference. A variant is a cluster of mutations, several of them that have all come together to form a new version of the original virus. So the Delta variant is not the same virus that we started with in 2020. It is also not a single mutation. We now have many mutations that are forming together to bring us these variants. That is why the variants have different levels, variants of interest, variants of concern. And we saw this Delta variant really take hold and put our vaccines under challenge, but they were not able to overcome them. Our concern is we might at some point get a variant that can completely overcome our vaccination and immunization status. And that would be for those who have native immunity, meaning they were already infected, and those who have vaccine, because both immunities may not protect against an emerging virus that is yet to be seen and yet to be known. So both groups are at risk. What we see is that the vaccines were much more highly protective against the Delta variant than people with native immunity. There was no comparison whatsoever with that. And so I understand that hesitancy, but the reason that you're thinking that is that the prevention of COVID-19 and its variants is not in those who've received the vaccine. Those variants develop in those who have not received the vaccine and are vulnerable. And then those variants put everybody else at risk, including those who are immunized. Okay, how does reporting vaccination statistics play into HIPAA laws? So I looked at this one for a minute. I really don't answer legal questions, but let's just say actually you meant statistics. I'm not sure. I was thinking that you just meant your vaccination information, but statistics are just anonymized data points. And so all of that can be reported. It does not have an individual's name. It's a grouping of information. So I might be able to give you all of the data in the Southeast region or the statistics on demographics, African Americans, Hispanics. Those are generalized, compounded data that is de-identified and brought together to bring you statistics, and it really doesn't impact anyone's individual personal health information. That statistical data, that's what we gather in VAERS, that's what we gather in VSafe, this is what we have with our Department of Public Health surveillance. So I'm wondering if actually what you meant is if your vaccination status, how does that play into HIPAA laws? Do you have to disclose your status of being vaccinated? And for that, I would say stay tuned. This is an area that's evolving, or consult an attorney. But the way that it's written, statistics do not impact HIPAA laws at all. But I think you might have meant individual vaccination status. I'm not sure. Are there any laws that prohibit employers or other service providers from discriminating based on health status or the decision to not report on medical status? So I saw this one as well, and that's going to be something you're going to have to refer to an attorney. I answer all of your science questions about the vaccines, about the virus, and not how we're going to manage it as a society with regard to your employability and the laws governing such. Since a vaccine is needed for COVID and there is no cure, what are treatment options once a person receives the coronavirus? So if you are infected with the SARS-CoV-2 virus, severe acute respiratory syndrome, coronavirus 2, that causes COVID-19, and you get an infection, here are your options. One are these monoclonal antibodies that you've heard people talking about. They're very expensive, but accessible. It's about $1,800 for infusion. I believe that they still are being made available through your health insurance or the US government. But it's an expensive therapy, whether you're paying for it or not. It's an infusion. You put an IV into you, and we give you actual antibodies to that spike protein. It lasts about 90 days that you have these artificially provided antibodies in your system to help you fight this COVID once it's invaded your body. It doesn't cure it. The point is to help mitigate your symptoms and keep you from being sick and keep you from being hospitalized. The other thing that we have that is coming down the pike is this Merck pill. What is this pill? What does it mean? So this is an antiviral agent that would have to be prescribed by a doctor. And once you have a positive test, you would take these pills for 5 days, twice a day. And it's a total of 40 pills. So this is no small task. So it's about 4 pills that you take twice a day. So it's 8 pills a day for 5 days. Again, the mechanism of action of the Merck pill is it interrupts the genetic process of the virus and therefore prevents it from replicating, not your genes, the genetic process of the virus, and prevents it from replicating. We add to that Merck, we won't. So that's one, the antiviral. Pfizer is also coming out with one that will be more like a protease inhibitor that's being used for the HIV patients and hepatitis patients. And they will combine that with a drug called ritonavir. And then Atea is also a company that is developing something called a polymerase inhibitor. But multiple companies are working on doing just that. Moderna is developing a combination flu COVID vaccine. All of these are in trial. Johnson & Johnson is developing a 2-dose vaccine series. So there is no cure. And something to know, we still, in this day and age, have no cure for any virus, be it cold, be it flu, H1N1, be it AIDS, be it hepatitis. We don't have a cure for viruses, but we are learning how to manage them and how to, sort of like cancer, how can you keep it in remission, even if you have to still live with it? How can you live a healthy life with it? So these viruses will eventually leave your body. And so the treatments that we have now and that are coming down the pike are to help you manage it and stay out of the hospital. If you're in the hospital, we can use an antiviral agent called remdesivir. We also have oxygen therapy, and depending on whatever complications you're having from the disease, all of those will be managed as well. So stay tuned. I think we'll have quite a few therapeutics coming to add to our arsenal. But don't forget what your grandmother always told you. An ounce of prevention is worth a pound of cure. Why would you take 40 pills or have an IV put into you and have antibodies infused into you when you can get a vaccine and not be sick at all? And the other thing to remember is that even if you receive some of these treatment options for COVID, you still have now been exposed and you have a risk, everybody, regardless of how severe their symptoms are, to go on and develop long haul syndrome. Long haul syndrome. You have deficiencies in memory, what they call this brain fog. You can get inflammation of your heart, this myocarditis, chronic shortness of breath. Previous athletes are winded after climbing just 1 or 2 flights of stairs. People have to go on disability. It's difficult for them to return to work if they have trouble recalling and remembering. If you are very young, this can be incredibly devastating in a career that you're just starting or you haven't started, or families that you haven't started, and you are having trouble catching your breath just walking up the front stairs of your home. So we need to understand that prevention is still better than the options. But if in fact you were to get sick, you're vaccinated and you have a breakthrough infection that's severe, which is rare, or you're not vaccinated and you get infected, these options are available. They're expensive. They require a lot of effort, and it doesn't change the fact that the virus now has gotten into your body and has invaded your body, and you might have some long-term sequelae.
Hey, Dr. Morgan, we got a ton of questions coming for you, and maybe
Okay.
want to hit a couple. First one, should people who have had COVID then got the vaccine consider getting the booster, or is the efficacy of the vaccine expected to be longer than in those people who never got sick?
Okay, so I think this question is about native immunity and vaccine immunity. So I can have multiple layers of answering this, but let me try to just cut to the chase. The vaccine immunity, meaning you get the vaccine compared to people who actually got the disease. What we know is that if you are immunized, we have reliable data regarding what your level of immunity is at any particular time. If you are infected with the virus, that is not true. That information on your immunity is variable and inconsistent. We know that almost everybody has great immunity for 30 days following your infection. After that, some people with this native immunity continue on at a fairly high level. It drops slightly, but then levels off. and it's pretty high at about 80% or 81%, while others completely tumble down towards baseline again. We have no way of knowing who's going to be who will be left completely vulnerable as their immunity wanes quickly, or how many will stay up at a steady state. So that is why we want everybody, whether you've had a vaccine or you've got the infection, to move forward with vaccination such that we have reliability and consistency with regard to what degree of immunity do we have in our society as we're reaching herd immunity. People who are only partially immunized or were immunized and then it drops off are a nidus or a sitting duck for the vaccine to find you and invade your body again. And you get a reinfection because you're now partially immunized. So we absolutely don't want that to happen. And so that's probably the answer to that. Now, here's the Dr. Jayne Morgan answer, which maybe is caught up in that as well. With regard to, if I've had the virus, do I need to get a vaccine? Don't I have enough immunity? And I've just explained why you may or may not. You may not. However, if you're moving forward the messenger RNA vaccine, there is an argument to be made, and listen to what I'm saying. That's not a scientific terminology. There's an argument to be made that literally means there is no data to prove what I'm about to say. There's an argument to be made that if you've already been infected, you probably only need one additional dose of the vaccine. The infection would serve as one dose, and then you just get a second dose. That is probable and reasonable, but there is no data on that. And in science, we have to follow the data. So until we have data, we want everybody to move forward with these vaccines as soon as possible.
All right, great. One question that has come up, Dr. Morgan, and I think you are uniquely situated to answer is, we've talked about the pros of getting vaccinated, but what are the cons?
Well, let's talk about the side effects of vaccination. Most common side effects, right? Nausea, chills, vomiting, headache, myalgias of these body aches, injection site pain. But what are some of these other ones that you've heard about? So let's talk about the one called myocarditis. And those are with the messenger RNA vaccine. So the Pfizer and the Moderna vaccines, myocarditis, an inflammation of the lining of your heart, very serious. It occurs generally in men who are 35 years of age or younger. And I've had people say to me, Dr. Morgan, why would I risk getting myocarditis and take this vaccine when I cannot get the vaccine and not have any risk of myocarditis? Well, for one thing, your risk of myocarditis is not zero in the general population, but let's just say it is. Okay, it's not, but let's just say it is. You're looking at the wrong populations. You're comparing people who receive the vaccine to healthy people in the general population. The comparator groups, the right comparator groups, are people who receive the vaccine versus those who've been infected with COVID. That's what the vaccines are doing, protecting you from COVID. So if you look at those comparator groups, those who get infected with COVID have a risk of developing myocarditis 450 in a million. As opposed to if you got the vaccine, and that side effect risk of myocarditis in men is 67 in a million after the second dose, and 77 if you also include the first dose. So that's a 7-fold difference. You've got to compare apples to apples. We want to compare the vaccinated group, the vaccine group, to the group that got infected. The group that got infected is 7 times as likely to develop myocarditis as the group that got vaccinated. The other side effect, lymphadenopathy. in women. And I want to let me say something about myocarditis as well, because I don't want to minimize it. It's very serious and you must seek medical care, but it is 100% treatable, 100% treatable and survivable, 100%. But you must seek medical care. I want to be clear about that. But it is treatable and survivable. Okay, we haven't seen any deaths from this. So the other side effect that you can have that is severe and a little more common is lymphadenopathy. Lymphadenopathy, swelling of lymph nodes in women on the same side of the body that you receive the vaccine. So you might have these axillary lymph nodes or lymph node that appears under your arm, or cervical at the back of your neck on the side of your injection. And so these are the kinds of things that can be very anxiety provoking. Imagine if you have a history of breast cancer, or you got a family history of breast cancer, or you're in the middle of a breast cancer workup, and you suddenly develop lymph nodes under your arms and in your neck and supraclavicular on top of your collarbone. That's really scary. The other thing is, if you develop these lymph nodes, they can cause what we call diagnostic confusion, meaning if you're having some type of radiography workup, it can obscure the results or provide artifact that can cause your radiographic exam to be misread. And then you may have to have even more tests that are unnecessary. So we want to be aware of that. It happens in about 4 or 5% of women. So that's not uncommon. It goes away on its own within 5 to 7 days. We don't want you specifically to avoid any medical treatment, including mammogram, including cancer workup, just because of the vaccine. We absolutely do not want anybody delaying medical care for the vaccine. Instead, what we want you to do is make sure you notify your doctor and notify the radiographer that you've had the vaccine, but still continue exactly on your schedule for whatever you are scheduled to do. You simply notify the doctor. They will absolutely know what to do. We look at the Johnson & Johnson vaccine. Johnson & Johnson vaccine, as you know, we had a pause April 13th to April 23rd because of these blood clots, right? So during that pause, they identified 15 women who had developed these blood clots. At that time, 8 million doses had been administered. Of these 15 women, they had CVST, it's called cerebral venous sinus thrombosis, a very specific type of blood clot. They looked at this series of 15 women to adjudicate, meaning look at all of these cases. When they looked at them, they noted that the real risk of a blood clot is 7 in 1 million in a very specific demographic, in women and in women between the ages of 18 and 50. Not only that, we noted also that 18 and 50 were really outliers. Most of those cases clustered between the ages of 34 and 40. Most of the women who developed blood clots were between the ages of 34 and 40. Still very rare, 7 in 1 million. And again, 100% treatable. We've had no deaths. Again, I will say it is serious, but it is also treatable. And as soon as you come to the hospital or talk with your physician and you tell them that you've had the vaccine, the doctors will know what to do. You have to be able to give your medical history that you received the vaccine. And then we absolutely can move forward with treating this blood clot, 100% treatable, but very serious. I want to be clear. But I also want to put it in context. It is rare. It's 7 in a million. And to give you a comparison, birth control pills, which are very common in our society, the risk of blood clots with birth control pills is 1 in 1,000. Imagine how often and common those are. 1 in 1,000. This is 7 in a million. The risk of you dying if you are in a car accident is 1 in 77. Your ability to be admitted to an emergency room anywhere in the United States with a pogo stick injury is higher and more likely than you to get a blood clot. The other thing is that Johnson & Johnson has one side effect of Guillain-Barré. Guillain-Barré is a specific type of neurologic disease, very rare. But in the trials, they had one additional patient in their active arm that developed Guillain-Barré than in the placebo group. And even just one person, you have to report it, but it's very rare. So those are the rarer, more serious side effects that are treatable that we need to look out for. And then there are all the common ones as well.
Great. All right, we're going to step right back into the questions. So Alfred, there you go. Thank you.
There are so many that use my body, my choice argument to push back against the vaccine potential mandates and their responsibility to protect others in their communities. What has been effective in convincing those that see the vaccine as an infringement on their personal freedoms? So, when you look at herd immunity, here's one way to kind of look at that. Herd immunity is a term that really denotes that as long as enough of us are protected, then all of us don't have to be protected. And we've always had a slice in our society of people who were not vaccinated. Why? Because we use live vaccines. We use live attenuated or live killed, right? And that means there are a lot of people where that was very dangerous. Children with leukemia, cancer patients, HIV patients, anybody with a weakened immune system, if you give them a live virus, they don't develop antibodies, they get the actual disease and will die from it. So we've always had a slice of our society that could not be immunized. But why do they stay healthy? They stay healthy because of this herd immunity. Because as long as the majority of people in the society in which they live are immune, then when plagues, that's the old term, or viruses come into our society, they literally cannot find a human being before they die out. So if most of the people are immunized, the entire society doesn't have to be immunized because the viruses have such difficulty finding any vulnerable person until they just die out. That's herd immunity. So when we talk about people who are my body, my choice, or they want to be independent, they are looking at that and saying, look at all these people who were never immunized before. They've stayed healthy, but the reason they've stayed healthy is because I get my vaccines and you get your vaccines and they get to live in my neighborhood, so they get to stay healthy. So the irony is, when people tout how healthy they are and how green their lives are and how they follow the best practices of everything, and so they now eschew vaccines, the irony is, it's not that they have reached some higher level of mental being or have achieved some superior state of physical status, or have even found just the right cocktails of vitamins that they take religiously every single day, or are practicing the best form of yoga. No, they stay healthy because I got my vaccine. So the irony is, in asserting your independence and pushing back against the vaccine, you now have become dependent on me for your health. And so this is the way to frame the context of what independence means. It actually changes you to a person who's now dependent on others.
That was powerful. So Alfred, let's go to the next one.
Why are individuals who have been vaccinated people not required to get tested? Okay, why are individuals who have been vaccinated not required to get tested, even though they can still contract the virus? Okay, so this is a great question. I'm going to try to make it as simple as possible. Antibody tests, which is what this is about. You're asking about antibody tests and why are people who are vaccinated not getting antibody tests? Our antibody tests are not foolproof. So antibody test for people who've been vaccinated often will come back as negative. The reason for that is that antibody tests measure something called the nucleocapsid. And the nucleocapsid is only formed if someone has had the actual infection. So it's good at measuring antibodies in people who've had COVID. If you haven't had COVID, but you got the vaccine, your antibody test is going to be negative because the vaccines don't produce nucleocapsid. The vaccines are designed against the S protein. So if you're going to have an antibody test and you've had the vaccine, you have to specifically make certain that the antibody test is testing for the S protein. That's very rare because we really never test for vaccine immunity. The other thing about vaccines is it's not all about antibodies. It's also about cell immunity, T cells and B cells, that humoral and cell immunity that's not measured that Johnson & Johnson has one side. Because this is so confusing and most people don't even have antibody tests that test the S protein, that's why you see the CDC and the FDA saying, please do not get tested. Because what happens is if you get a negative test, you're like, oh my God, the vaccine didn't work. And then you might go out and get a third shot because the first two didn't work or the first one didn't work. Or if you haven't been vaccinated and you have a positive test, let's say you got the infection, you might have a false sense of security and you go out and live recklessly in the middle of this pandemic. Because what we don't know with these antibody tests, we see that you have antibodies and we can even tell how many you have. But what we don't know is what is the magic number that confers immunity? That we don't know. So I'm just making it really simple. Let's say you took an antibody test and you came back with a 95. The best you can get is 100. That sounds really good. You got a 95 and you might go out and just do whatever because now you feel pretty protected. What we don't know is 95 protected or does it have to be 99? Is 50 just as good as 95? If you have 50 for your antibody test, is that just as good at 95? So both people have antibodies. Is one better than the other? We don't really know. Does one confer immunity? We don't really know. So you see how confusing it is. And that's why we are asking people to not get tested for their antibody status after they've been vaccinated, because you probably aren't going to know how to interpret it, or it's going to be uninterpretable.
No, appreciate that. So we are close to time, Dr. Morgan. We've got about 6 minutes. I want to be respectful of everyone's time.
Yeah.
Also, as a reminder in the chat, folks, let's just be civil. We can have a good civilized debate. Civil discourse is important, so just remember that. Dr. Morgan, let's try to hit this question and maybe question number 10, and then we want to give you an opportunity to promote your Stairwell Chronicles and whatever else you want to bring forward.
Okay, so if the vaccines are so effective and required, why are we not administering the same vaccine to young children? And so we are and we aren't. So it is the same vaccine, but don't forget, other than Pfizer, these vaccines are under emergency use authorization. So we have to do something that's called bridging down, which means we start in adults, 18 and older, and then we look at the next group, 15 to 18-year-olds. Then we look at the next group, 12 to 15-year-olds. Then we look at the next group, 9 to 12. Then the next group, 6 to 9. We gradually get younger and younger and younger. And we compare that data to the older groups. So it's the same vaccine, but we gradually bring in younger and younger pieces of the population over time, always comparing it back to the older populations. So maybe what you mean by the same vaccine is that the dose will be less. So it's the same formulation with a lower dose. So don't forget, children have immune systems that are not as mature and are still evolving and developing. And so we want to have an acknowledgement of what that is. And always in medicine, we always follow the same mantra, is that we try to give the least amount of medicine for the most effect. So we want to find what that is in children, and it may not be the same for adults. And I think you saw in Pfizer, the dose was decreased by 2/3. So the dose will be 10 micrograms instead of 30 micrograms. And that's the right thing to do. That's a dose finding study. There's no need to give children 30 micrograms for 100% effect if they can get 10 micrograms and still get 100% effect. So there's no need to give them 3 times what they need. So.
Fantastic. And before we get to question 10, I have to ask you this because I think it's important for people on this call to hear. In your opinion, Dr. Morgan, how can a company like Microsoft get involved to do bigger and better things to help overcome vaccine hesitancy and issues like that in healthcare?
So, this is always a challenge. And I think the best way to do that is what we're doing here, having people have an opportunity to submit questions. Also, open dialogue. I would be welcome to talk with people if they just unmuted themselves and want to talk with me directly. But I think the best thing is to get your questions answered and to kind of come out of a lot of these social media rabbit holes. So, one of the ways, obviously, that we know social media works, we all know this, is that if you have a question, you might go on and click on something and it answers the question and it sort of validates what you were thinking, whether it was right or wrong. Let's just say in this case, it was wrong. And then what happens? The algorithm starts feeding you more and more and more of the same information, which then reinforces the initial false premise. Then it introduces you to other people who are also a part of this false premise. That's how social media feeds you and stays in business. And the next thing you know, you're down this rabbit hole. Everybody's thinking the same and sounding the same. And so it sounds right? They throw in a few science words. It sounds really good. And it's like rabbits in a hole. All the rabbits start reproducing. Next, there are thousands of you down there. And we want to come out of these social media rabbit holes and understand the power of social media for good and for bad. So be careful what you're clicking on, because those clicks then feed you into more, and then feed you into social chats, and then feed you to other people. And then this negative and incorrect information starts to feed on itself. And it's always hard, right, to get the horse back in the barn after it's galloping around the track, whether the track is muddy or not. So be careful. I do an entire Stairwell Chronicle on misinformation and how to spot misinformation.
Well, why don't we go ahead and segue to plug that, Dr. Morgan?
Oh, yes, absolutely. So you guys can follow me if you like. I am on all the social media platforms. I'm on Twitter, Instagram, YouTube at Dr. Jayne Morgan, and you can see me. I do something called the Stairwell Chronicles, where literally I sit on the steps and I answer a question about COVID or the COVID vaccines in 60 seconds or less. I've probably done 70 or 75 of them. If you have a question, you can look through the catalog. If you have a question that's not there, DM me. Maybe I'll do a Stairwell Chronicle and answer that question, because if you have it, other people have it as well. It's only 1 minute. If you don't like what I've said, you can't be mad. I didn't waste that much of your time, right? So it's 60 seconds. It's called the Stairwell Chronicles. Twitter, Instagram. I have an entire YouTube channel. On YouTube, you can see multiple media interviews that I've done, all in Atlanta, national networks, international networks, radio, and listen to me then have conversations, short conversations. Media interviews are 3 to 6 minutes where they're asking me questions and I'm talking. And at least if you feel hesitant or resistant or suspicious, start to have a source where you have other information as well. Don't stick with the same information. Remember, that's what social media wants you to do. That's how they make their money. So the other thing that we understand about social media, right, is that the more emotional that it can make you, the more likely you are to continue to return, continue to return, continue to return. So science isn't that emotional, right? I've never read a science textbook and called my friend and talked about, I laughed, I cried, I was all over the place emotionally. It was the best book I've ever read. Science is kind of dull. In fact, I sat in on the FDA Pfizer briefings 3 weeks ago, 7 hours of data, documentation, presentations, arguments, discussions in the middle of a pandemic, and I'm leading the COVID task force, and I nodded off for 45 minutes. And you know how that goes. You don't know you're asleep till you wake up. You're like, oh my God, I was out. Science isn't that sensational. So if you're in sites and you're getting all worked up, you might not be looking at science. So here's an example of my Stairwell Chronicles. You'll see my faces. I'm sitting on the steps, and you'll see the topics. I never take vaccines, and I'm always healthy. Hear me talk about it for 60 seconds. Boosters and the immunocompromised. Hear me talk about it for 60 seconds. Now that I'm fully vaccinated, can I still transmit COVID to others? Hear me talk about it for 60 seconds.
All right. Dr. Morgan, thank you. You brought a lot of education, a lot of passion, a lot of fire. So that's fantastic. Alfred, let's turn it over to you.
Thank you. Thank you, Dr. Morgan. Love the energy, love the content. Love the content. Hopefully you can hear us. We're looking forward to perhaps even bringing you back because of the information that you've shared. And for those of you that have asked questions in the forum, we do have other sessions coming up, but we definitely appreciate you guys giving us your feedback. We've also listed a few give campaign options for you guys in case you're interested. Happy to share it as part of the deck afterwards. These are things that you can actually volunteer for, whether it's your time or whether it's your contributions. That would be great. And then last, I just want to say thank you to the team of folks. Again, sometimes people think it's just one person. Behind the scenes, you've got all these folks, Kimberly, Jamal, Rasul, Desmond, all actively working to put these sessions together for you around healthcare. So I just want to say, from the bottom of my heart, thank you to them and for this team to making sure these sort of sessions continue to happen. So the session will be recorded. It will be available for you afterwards. Please continue the dialogue. Please continue the conversation. Please follow Dr. Morgan. She has a lot of good information to share, and I know she's looking forward to sharing it with you. And then lastly, we have another session coming up at the end of the month with Dr. Rue, with which we will continue the conversation, and perhaps some of your additional questions will be asked. Again, thank you guys for joining today, and we'll let you guys go back to the rest of your day.
Thank you, Dr. Morgan.
And I appreciate inviting me back. I see lots of great questions about African Americans and our historical context. I give a lot of talks on that. You can go on YouTube and hear me talk about research on African Americans, not just the Tuskegee experiment. And I see questions about all of the data being presented. And I can talk about that VAERS database if you ever want to hear me talk about it and what that means and what those numbers really mean and why I think that we should probably not do your own research because you're misinterpreting those data and those numbers as well. You don't understand what the VAERS database really is. So anytime you want me to come back, I can address those. Those are big topics. I can talk about it, but go on YouTube. You hear me talk about both of those as well.
Will do, Dr. Morgan. Well, thank you very much.
All right.
We look forward to having you back.
Thanks.
All right,
Bye.
everyone. Take care.
Thank you.
Awesome session.